We'll turn the time over to Dr. Sommavilla, your colleague, who's going to be presenting on surgical considerations. Dr. Sommavilla.
Hi, thank you. And thanks for the opportunity to come here. Thanks to all the patients for participating, and thanks to Dr. Shepard and Dr. Hurley for their very interesting talks. Can everybody see my screen and hear me okay?
Yes, it's good to go.
So I'm going to be talking, my name is Joshua Sommovilla, and I'm a colorectal surgeon, also working at the Cleveland Clinic as part of our Weiss Center, which specializes in treating patients with hereditary GI cancer syndromes, one of which is FAP. So we do see a lot of patients with familial polyposis as part of our program, and we see a lot of patients with desmoid disease. And I'll be talking about surgical considerations for desmoid disease in FAP patients. So just to kind of overview what I'm going to talk about, I'm going to first take a step back and highlight the importance of how we think about desmoid disease when we operate on any patients with FAP, even if they don't have desmoids at that time. And then I'll talk a little bit about how a patient's risk of desmoid disease impacts our thinking about surgery in FAP patients. And often this is our thinking about colon surgery, because colon surgery is often the first operation that a patient with familial polyposis will have in their life. And then I'm going to talk a little bit about special considerations that we take into mind when we are operating on patients who have established desmoid disease, and some of the surgical options that we have for patients with desmoids. So just take a step back and talk about familial adenomatous polyposis. I just want to cover some of the basics. I know that many of you probably already know these things, but I think this kind of helps establish the rationale for how we think about desmoids in these patients. So the APC gene is on the 5th chromosome, and a mutation, everybody has two fifth chromosomes, and a mutation in the APC gene on one of those two chromosomes will result in FAP. This carries nearly a 100% risk of colon cancer during a patient's life if they don't undergo prophylactic surgery. Now, this risk varies because depending on where that mutation on the APC gene is, some patients will form thousands of polyps very early in life. And I saw somebody ask earlier what attenuated FAP is. That's a term that we use for people who tend to form fewer polyps. So these are people who have, dozens of polyps often in childhood, but they're often manageable without surgery for a long time. Sometimes patients with attenuated FAP will be able to live without developing cancer, even into their 40s and 50s. But nevertheless, most people who have the APC gene mutation will at some point develop colon cancer if they don't have a prophylactic operation. In addition to the risk of colon cancer, FAP carries other significant cancer risks. This is in the duodenum, the first part, which is the first part of the small intestine, the thyroid gland, and as we're seeing a little bit more, even in the stomach and some other organs as well. And then there's a significant risk of desmoid tumors, which, depending on what type of study you look at, is about a 15 to 30% risk throughout a patient's life. And as Dr. Shepard mentioned, this is much higher than the risk of a desmoid tumor forming in a person without FAP. But because FAP is relatively rare, if we took all the desmoid tumors that are seen in our entire population, most of those would be in patients who don't have FAP. And similarly, like Dr. Shepard mentioned, we don't really consider these to be true cancers, but they are tumors that can cause significant problems, and actually are, depending on the study that you look at, either the second or the third leading cause of death in patients with FAP. But in addition to, they don't just cause death, but they cause a lot of symptoms and problems. And this is touching on things that have already been mentioned. They can be locally aggressive, even if they don't grow into things. This is just a CT scan, which I understand many people here are probably not used to looking at, but I'll hover with my mouse. This kind of lighter area here is a desmoid tumor, and it's not particularly big, but you could see these hollow black structures. That's the intestine, and this looks a lot dilated, which means that the desmoids are causing a blockage in the bowels. So that's one thing that desmoids can cause. And also, like mentioned before, when the desmoids stick to the bowels, there can be an inflammatory reaction between those two things that can cause the bowel wall to kind of break down and form what's called a fistula. And that's basically where the bowel will open and develop an abscess in the abdomen, causing somebody to get really sick or even septic, or it can erode through the skin to where stool will drain through the skin as a result of the relationship of the desmoid tumor and the bowel. Because of where they sit, desmoid tumors can also block these structures called the ureters. These are tubes that carry urine from your kidneys to your bladder. So if these get blocked up, the urine can't travel as it should from the kidneys to the bladder, and the kidneys get swollen because they can't empty their urine. And this can cause kidney failure. This can cause infections that can even become life-threatening. So these are all really significant problems that can result from desmoid tumors, even if they're not spreading to other parts of the body as a traditional cancer would. And they also can cause bleeding. They can grow alongside major blood vessels and cause bleeding as a result of that. So it's really important where we can to prevent desmoid disease when we can. And part of the rationale in preventing desmoids is to know the risks of patients and families. Some people with FAP are at higher risk than others of forming desmoids. We also know that just having surgery is a big risk for desmoid formation. So most FAP patients will develop desmoids after having another surgery, usually a colon operation. And so I'll talk a little bit more later about whether the different operations that we do cause greater or less risk for desmoid formations. And so how else can we prevent desmoid tumors? And the first step, as I mentioned, is knowing the risks. So we've looked at this a lot in our FAP patients at our institution, and we found, looking at risk factors that have nothing to do with the way we're treating a patient, things that are just kind of inherent to a patient and their family, there are certain things that place patients at higher risk for forming desmoids throughout their life. One of those is gender. So female patients are more likely than male patients to develop desmoid tumors. Patients with certain FAP manifestations in other parts of their body outside of their colon are more likely to form desmoid disease. So people will sometimes form these lumpy, bumpy lesions below their skin, or benign growths in their bone, or patients will have extra teeth. We know those patients are more likely to develop desmoid tumors. One of the biggest risk factors is just knowing that there's desmoids in the family. And then finally, when we look at the APC gene, depending on where the location is on the gene, we know we can identify patients at higher risk of forming desmoid tumors. None of these things are perfect, but they help give us an idea. And so then, as I mentioned, most desmoid disease occurs after another surgery. And we think that something about surgical trauma sets off changes that allow genes to further mutate and allow desmoids to form and grow. And also, like I mentioned, the most common first surgery that we do is colon surgery. So I'm going to talk a little bit about the colon surgery that we do. Even though it's not directly related to desmoids, we think it might have some impact on the formation of desmoids. So this cartoon on the left shows kind of normal colon anatomy. Your colon, this is all of your small intestine, which you have several feet of. And all the blood vessels to both your small intestine and your colon travel in these sheets of fat that are called the mesentery. And this is where desmoid tumors typically form, in the mesentery of the small bowel or of the colon. And then, this is your colon, starts here on the lower right side of your body, near where your appendix is, and it travels up your abdomen, over to the left side, down the left side. And then the last part of your large intestine is called the rectum, which is about a foot long, and that goes down to where you empty out your poop. So when we're thinking about surgeries that we do when patients have an uncontrolled number of polyps in FAP, there's one operation called a total proctocolectomy. That's where we remove the entire colon and the rectum. There's what's called a subtotal colectomy, which we really don't do much of, where we leave a little bit of colon and the rectum in place. And then we have what's called a total abdominal colectomy, remove the entire colon, but leave this last foot of the large intestine, which is called the rectum, in place. And our decisions about which of these operations to do has to do a lot with the patient's colon cancer risk, in particular their rectal cancer risk, so the number of rectal polyps that they have before surgery. But as I'll mention in a little bit, also has a lot to do with what we think about their desmoid risk. So when we leave the rectum in place, we often reconstruct things with what's called an iliorectal anastomosis. So that's when we bring the end of the small intestine down and reattach that to the rectum. So this is, we remove the entire colon. That's a total abdominal colectomy with an iliorectal anastomosis. An anastomosis is the word we use in surgery for a connection of two things. In patients who need to have the rectum removed, so we remove their entire colon and the rectum, we often create what's called a J pouch, which is making a pouch-like formation out of the small intestine and connect that directly to the anus. Because of the complexity of this surgery, we'll often give patients a temporary ileostomy bag with this operation. So these are the two most common surgeries that you'll see us do now in patients with familial polyposis. When we're deciding on these operations as surgeons, we're always thinking is, does the operation that I do, we're always thinking about desmoid risk in patients with FAP. So one thing that we wonder is, does my choice of the operation that I'm going to do impact a patient's desmoid risk? And does the way that I approach it, so, traditional open surgery with a big incision, or what we commonly do now is laparoscopic surgery with small incisions and cameras and long instruments that we can use inside the belly, does that approach affect desmoid risk? And our group has long hypothesized that something about when we create this J pouch that we connect down to the anus, that will cause extra stretch on the mesentery, which is where desmoid form. And does something about that stretch make desmoid formation a little bit more likely to happen? And when we looked at this in our own patients, we did find, and this is a study that we did where we just looked retrospectively, so we didn't collect this data as we went, but we looked back on all the operations that we did for FAP, and we did found that patients who had a pouch surgery, this is the blue line here, typically more commonly form desmoid tumors and form them earlier time point after surgery compared to patients who had their rectum remaining in place. Similarly, we found that patients who had open surgery formed desmoid tumors a little bit more commonly than patients who had laparoscopic surgery. And we found this to be a pretty significant factor. So these are what's called odd ratios. So the higher number means the more strongly that factor played a part in desmoid formation. And we found that the surgical procedure was even a stronger factor than, slightly stronger factor than things like family history when causing or being associated with desmoid formation. So this is just to kind of tie up thinking about surgery and how we think about surgery to reduce risk of desmoids. When we identify patients who we think are high risk for forming desmoids after surgery, number one thing that we do is try to manage them without surgery for as long as possible. So keeping up on their polyps with colonoscopy and really delaying surgery by removing polyps with colonoscopy for as long as feasibly safe to prevent colon cancer. Because even if we do a less risky surgery for desmoid formation, it's still better, it's still a higher risk than no surgery. But in these people, when surgery is ultimately needed, if it's possible to keep the rectum in place without creating a too high of a risk for rectal cancer, to do a total colectomy with an ileorectal anastomosis rather than a proctocolectomy with a J pouch. And we think, the evidence isn't as strong about this, but we think that laparoscopy might be beneficial compared to open surgery. So I'm going to transition a little bit and talk about patients who have established desmoid disease and how we think about surgery for desmoids. And compared to surgery for other cancers or preventative surgery on the colon to prevent colon cancer, surgery for desmoid disease is usually geared towards a specific quality of life issue or a symptom, not to curing the disease. Part of this is because desmoids often form in this part of the mesentery, which I've shown before, where removing the desmoid tumor would compromise all of the blood flow to the entire small intestine, which is not something that you can remove and leave a person with a good quality of life from. So we really try to address, where possible with surgery, the symptoms that desmoids are causing. I mentioned some of the symptoms earlier. Part of this we look at is we stage desmoids by both not just how big they are, but by how fast they're growing and what kinds of symptoms they form. And as you can see here, severe symptoms would be considered a bowel blockage or a bowel fistula or a urinary blockage or bleeding. Those are the most severe symptoms that we consider when we're thinking about having to operate for desmoid tumors. This is always a balance, right? So some patients will form desmoids on their extremities or their abdominal wall, and those are easier to do surgery on without causing major consequences or side effects. So we have lower threshold to do surgery in those situations because the risk is lower. When desmoids form at the root of the small bowel mesentery, the risk of surgery is very high. So we try to maximize the medical treatments and other things as much as possible before we do surgery. I just wanted to point out one other thing. So we talk often of desmoids as tumors, but we often also see something called desmoid sheets, where I know you're not used to looking at pictures like this, but this is the small intestine, and this is that fatty tissue where the blood vessels flow called the mesentery. And these white plaques here are desmoids, but they're not tumors, they're not masses. They're just sheets of tissue which are very thin. and they can cause a lot of problems. They can cause the bowel to stick to them, and they can even cause blockages, even without growing to the point where you can even see them on a CT scan. Sometimes we identify these things just at the time of surgery when we didn't know a patient had desmoid disease. So when patients have severe symptoms related to desmoids, as I mentioned before, we can often remove abdominal wall, chest, or extremity desmoids because removing them may not have a major impact on quality of life or a lot of major downsides to it. When people have a bowel blockage from a desmoid tumor that's not removable, there are options that we can relieve some of those symptoms while leaving the desmoid tumor in place. So sometimes that would include creating a stoma, which is bringing up a loop of the intestine to the skin to empty into a bag. And that will allow relief of a lot of those symptoms without the high risk of removing the desmoid tumor and a large amount of small bowel. Sometimes, depending on where a desmoid tumor is located, we can bypass the desmoid. So that would allow a person to live without a bag, without the risk of removing the desmoid, and just basically bypass one segment of the intestine to another and relieving the symptoms. When the urine tubes, the ureters become obstructive, there's a lot of options for that. Some are placing stents in those structures to allow the urine to pass. Sometimes we have to place drainage tubes into the kidney to allow the urine to drain externally into a bag. And sometimes a urologist can do an auto transplant. So it's similar to a kidney transplant, but instead of transplanting a kidney from another person, you just transplant a kidney from the same person to themselves, just in a different place where that urine tube isn't blocked. And then when people have mesenteric desmoids that don't involve the entire blood flow of the small intestine, we can sometimes remove those with a segment of the intestine and reattach things without having to compromise too much of the intestinal length. So small desmoids like this can often be removed, but like I was mentioning before, this CT scan shows a very large desmoid, and this white dot here is the artery that brings all the blood flow to the majority of the small intestine. So as you can imagine, removing this desmoid tumor would require removal of almost all of the small intestine, which would leave a person in a position where they're not able to support their nutrition and would rely on a lot of supplemental nutrition to be able to continue to live. And so one of those supplements that we give patients that they have to have a large amount of their small intestine removed is IV nutrition called TPN. And this is really, it's not a cure-all. Somebody who has to live on TPN it's pretty high risk. You need to have IV access permanently, and that can lead to infections. TPN long-term can cause liver failure and cirrhosis, and having these IVs in place long-dwelling can form life-threatening blood clots. So leaving a patient in a position where they have to live like this is not really a great option, which is why we try to avoid operating on some of these desmoid tumors if we can manage the symptoms in other ways. And just before wrapping up, in some patients, and I just want to make sure I'm clear about this is just a very small select number of patients, small bowel transplant may be an option for managing severe desmoid disease. I'd say, before the last few years, we've had a pretty bad experience at our institution with small bowel transplant outcomes, and they're starting to look a little bit better. And these are options for different intestinal transplants when the majority of the small intestine has to be removed. So our transplant surgeons can do intestine-only transplants in patients who maybe have developed liver failure related to longstanding TPN. They could do transplants of both intestine and the liver, and then even other organs together with that if needed. As I mentioned, the initial outcomes with this are very poor. And to this point, we've only transplanted, I think, 9 or 10 patients with desmoid tumors. It requires medications that suppress the immune system for the rest of your life, which can lead to infections and other problems. Small intestine transplants are not offered at more than a small handful of transplant programs in the country. So there's a significant issue of access for a lot of people. And as I mentioned, it has a very high rate of complications and a higher rate of death compared to other big surgeries that we do. But for some people who don't have a lot of options due to really severe desmoid disease, it may still be the best option. So just to summarize, desmoid disease is a really significant challenge, especially for surgeons who take care of FAP patients, and obviously more than anyone for the patients with FAP. we have to do more work to figure out ways to prevent desmoid disease formation. In addition to some of the factors I spoke about earlier and some of the things Dr. Shepard talked about earlier, we don't know if any of those medications that we use to treat desmoids might be beneficial in high-risk patients to prevent them from getting desmoids after they having surgery. So one thing that we're looking to do at the Cleveland Clinic and with some other institutions is potentially doing a trial to see if either Sulindac or other medications, when given around the time of surgery, might lower the risk of desmoids forming in the first place. Surgeons, we have to consider desmoid risk when we're planning out our other surgeries, even people who don't have desmoids, and that surgery for desmoids is challenging and should be directed towards specific symptoms. And I mentioned about intestinal transplant. It's promising, but it's a high-risk option and only a reasonable option for a very small number of select patients. So I really enjoyed having the opportunity to speak with you, and I'm looking forward to talking about any questions here.
Thank you so much. I'll just go into a couple of questions that are remaining. Dr. Shepard's been answering a lot of them. Outside of the correlation between FAP and desmoids, I thought desmoids were not hereditary. Seems that Dr. Sommavilla just mentioned they are or can be. I guess we just need clarification on that for this patient.
So all of the studies that I was showing and talking about were specific to our FAP patients. So that was all within the context of FAP. So patients with a family history of desmoids, when I was talking about them, those were patients who had FAP and a family history of desmoids. We have a lot of FAP families where nobody in the family has gotten desmoids. And as I mentioned, some of that's related to the location of the mutation on the APC gene, but there are other things that we probably don't understand as well as we could about what predisposes some FAP patients and families to desmoids more than others. I'm not aware of other hereditary conditions that are associated with desmoid disease, but again, my area of expertise is in FAP. There may be something else that I don't know about, but yeah.
Okay, so if it's an inherited disease, but no one in your family has ever had it that you know of, can you be the first one to be having that disease and passing it down to your descendants?
Definitely. So about 1 in 5 patients with FAP will be what we call de novo mutations. So that mutation in the APC gene, it can develop early in development of an embryo, which means that person did not receive that mutation from their parents, but it developed spontaneously. Now, usually those people will be at risk of passing it to their children, but they wouldn't have necessarily known from a family history that they had it because they're the first person. So, every family with FAP at some point in their history had a person who probably developed that mutation spontaneously in a way that allowed them to pass it on to the rest of their family.
Okay, and as a matter of course, Dr. Shepard mentioned that I always want to know if a desmoid has the APC, patient has the APC mutation. As a matter of course, do you always do that genetic testing before surgery or treatment?
Yeah, I would. And Dr. Shepard probably knows this better than me because almost all the patients that I see with desmoids already come with an established diagnosis of FAP. But certainly if I were to see a patient with desmoid disease, especially desmoid disease in the abdominal cavity, I would want them to have FAP ruled out before I made any final decisions. And I see this question about desmoid sheets occurring in patients without FAP, or is it only FAP related? I would say not just desmoid sheets, but really, desmoid tumors in the small bowel mesentery is highly indicative of FAP. So my understanding is like most patients who don't have FAP who form desmoids, it's usually in the abdominal wall, extremities, sometimes in the abdomen, but usually not in the mesentery or retroperitoneum. And those types of desmoids are much more likely to be in FAP patients. And I haven't seen desmoid sheets in patients without FAP.
Okay, one last question. I'm excited to hear that desmoid risk is starting to be studied and calculated into the risk of colon or abdominal surgery for FAP patients. You guys rock.
Thank you.
I would agree with that final comment. All of our presenters rock. What incredible information we've been able to get today. Thank you so much for being here and answering all these questions and imparting all of your great knowledge and experience. We appreciate you all. Dr. Hurley included, Dr. Shepard, Dr. Sommavilla. I'm going to turn the time back to Lynn Hernandez for some final comments as we close our day.